Waalaikumsalam.
Good afternoon.
Good afternoon, Doctor.
All already came, or you are waiting for anyone more?
I think we are still waiting for 6 people.
There is one now asking you to come. Okay. So let us start by Al-Kitab. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم. Today you are presenting an important subject. Okay, my goal is just to help you to increase your theoretical knowledge, but the main importance is how to get experience about critical care, because critical care is really the time which you can save patient. The patient will be between life and death. That's why to apply the verses of Quran ومن أحياها فكأنما أحيا الناس جميعا, it will be applied to some situation like that urgently. Of course, it will help us to be understanding globally what is the care of the patient, and even after the patient has loss of consciousness or like that, what is our plan after that. There is a fixed books now speaking about the post-resuscitation care. The patient already arrested and you did your job, how to continue for that. Of course, the differential diagnosis and all this, you are trying to cover it, and let us start now. We are 25 students of 28. Who will be the first presenter? Okay, خلاص. 2 already came. Good. Let us start. Please, everyone can turn off his mic, so no need to disturb the one who is getting the screen. And if you need, you can open it if you need to discuss or ask after that. Okay? Go ahead.
Okay. Can everybody hear me? Hello?
Yes.
Yes.
Yes, okay. So, Assalamualaikum warahmatullahi wabarakatuh. Okay, so we are going to present to you about problem-based seminar 6, which consists of child with altered consciousness, child with joint pain, and child with prolonged unexplained fever. So next slide. I am Amira Bintamuddin. I'll be presenting about child with altered consciousness. So my outlines will be next, definition, pathophysiology, etiology, and the approach. Moving on to the investigation, and last but not least, the management and outcome. Okay, so based on the Nelson Essential of Pediatric, consciousness is defined as awareness of self and environment, which includes time and place, and this is a cortical function. So the next term is arousal, which is representing the system that initiates and maintains the consciousness, which is ARAS system. I would explain later. And then the next term is lethargic. Lethargic is difficulty in maintaining the aroused state and maintaining the system. While obtunded is there is a decrease in arousal, but still responsive to stimuli, like verbal stimuli, light stimuli, pain stimuli. But stupor is unresponsiveness except to pain stimuli. Okay, and the next term is coma, which is unresponsive unconsciousness that is caused by dysfunction of everything, cerebral hemisphere, brain stem, and both. Okay, so this spectrum of disease, consciousness, disorder of consciousness is starting with the mild consciousness, mild lethargy to coma and leading to the brain death. So you can see as illustrated in the picture, which is based on the GCS score. Okay, the next slide will be pathophysiology, which is about ARES, which is ascending reticular activating system. So the function of consciousness itself is dependent on two components, which is our cerebral cortex and also the neurons at ascending reticular activating system. So this circuit, it begins from the brainstem and it connects into the cerebral cortex. So we gain the reticular formation, which is as you can see in the diagram, it is taught, we gain information from the cortex, from the spinal cord, and from the sensory pathway, and this reticular formation would go to the cortex back with the efferent connection of the reticular formation. Like, so basically this reticular formation is a sensory information pathway. And as you can see at the diagram above, figure above, which is the ascending projection is responsible for arousal and tension, while the descending projection is for the control of muscle, respiration, and arterial pressure. Okay, so loss of consciousness will occur if these neurons and cerebral cortex are affected. So we need adequate nutrients, oxygen, normal intracranial pressure, normal neuronal activity, no infection, no toxicity or poisoning to maintain the proper function of both cerebral cortex and ARES for consciousness. Okay, so next. So these proper functions can be affected if depending on the etiology, like infections, metabolic derangements, systemic disorders, or if there is any increase in intracranial pressure, poisoning, trauma or non-accidental injuries, seizures or strokes. So this group based on Nelson Essential of Pediatrics. However, what I listed is based on the protocols guideline that causes that need to be considered. So for example, in infection, we need to consider TB meningitis or bacterial meningitis, viral encephalitis, brain abscess or cerebral malaria. And then for metabolic derangement, we need to consider hypoglycemia, diabetic ketoacidosis or inborn error metabolism. For systemic disorders, we need to consider vasculitis, especially lupus, or hypertensive crisis, encephalopathy, or demyelinating disease like ADEM. Okay, ADEM is actually acute disseminated encephalomyelitis. It is actually similar to multiple sclerosis, dia punya presentation. It is a disorder that is can occur in children due to viral infection. It is basically an inflammatory response that affect white matter or basal ganglia. Okay, so there's another mention of ANEC in the footnote, acute necrotizing encephalopathy of childhood. This is also mentioned to be considered in guideline, PITS protocol, because ANEC it is a disease, bilateral thalamus disease that is rare but can occur in Southeast Asian in your population. Okay, so the next one in systemic disorders can be considered hepatic dysfunction or acute renal failure. In increased ICP, we consider acute hydrocephalus or brain tumor for poisoning, like toxins or withdrawals. For example, any drugs like barbiturates or anticonvulsants, or even toxins that is being ingested by the children. For trauma, any trauma that could lead to hemorrhage. Non-accidental injury is very important to be considered because we don't know what is happening to the children, and we should find the sign or symptoms of abuse, and then seizure, like status epilepticus, or if the loss of consciousness is due to post-ictal state, and then last but not least, stroke. Stroke can be due to hemorrhagic stroke or cerebral venous sinus thrombosis or sinovenous thrombosis. Okay, so the terms is interchangeable. Okay, so this grouping is based on Nelson. However, actually, like hypertensive crisis can also cause increased ICP, or even stroke can cause increased ICP. It is basically just classification. Okay, so next slide. The approach for if a patient come to you with loss of consciousness, so this is an emergency situation. The primary screening and then the secondary screening. So first of all, primary screening, we have to do the initial assessment and then assess the GCS, and after that we would move on to the secondary assessment, looking for the underlying etiology and treat it, investigation and manage the patient. Okay, the next, we move on one by one, which is the initial assessment. According to the guideline, we would do primary screening of ABCD, which is we secure the airway and consider endotracheal tubing if it is severe, and look for the breathing. If the respiratory function is adequate, or the children need oxygenation or artificial ventilation, and circulation, basically to treat if there is any shock, we would give IV bolus, inotropes, or chest compressions. And D in the guideline, D is actually dextrose stick, which is to treat hypoglycemia promptly if there is low glucose. Okay, and then the next thing is to monitor the vital signs, basically to look for any Cushing triads, if you could remember Cushing triads. Okay. The next thing is to assess the GCS. This is under D2, which is disability. For Glasgow Coma Scale in children, it is modified because of the difference in children and adult is basically the verbality. Their children, the non-verbal children, has special way for us to assess the Glasgow Coma Scale. Like you can focus on the best verbal response. Okay, for assessment of Glasgow Coma Scale, first of all, we need to look at the child, observe. If the eye is spontaneous, then we would give the best score of 4. If we say hi, and then the child open the eye, then it is 3, meaning that it is responding to the sound. So if only respond to the pain, how do we assess the pain? Is we apply pressure to the fingertip, pain, then we will give 2, okay, fingertip pressure, or if not, trapezius pressure, or last supraorbital notch pressure, basically to give pain. And if they can only respond to this pain, the score is 2. or if none at all, no response, 1. Okay, so in verbal response, the baby usually come to you. If you interact, they can cooes or babbles. Okay, that would be 5, the best score. If they come to you irritably crying, that would be 4. So if the cries come after you apply pressure, that would be 3. And if the baby only cries slowly, like moans, then it will be 2. So, but however, children is if they come unconscious or we already intubated, so the best response to look for is the motor response. So if the patient, okay, for adult, if we ask the adult, for example, come with fracture of the right hand, and then we ask, okay, raise your hand, left hand. If they can obey the command, and this is 6. But if we ask, okay, sakit kat mana cik? Okay, where is the pain? Then adult usually can localize the pain, show it's the left hand. But children cannot. So what will they do? They would withdraw from the touch if they are still good conscious. If only respond to pain, we apply pressure, then it is 3. So if no response to the pain or the abnormal flexion posture to the pain, then it is 2. And abnormal extension posture to the pain, it is 1. If there's no response, 1. Abnormal extension posture to the pain is 2. Abnormal flexion posture to the pain is 3. Okay, so 3 and 2. So can you guess what is abnormal flexion posture? Who wants to guess? What is it? Abnormal flexion posture. No. Decorticate. Okay, abnormal flexion posture is decorticate. Abnormal extension posture is decerebrate. Okay, I will explain to you later about the pathophysiology. Okay, next is the guideline recommended that if we have to monitor GCS hourly if the patient has more than 12 and more. If the GCS is lower, then we have to monitor more frequently, like half hourly until it improves. Okay, so the next slide is about what? Next, okay. Okay, this is this is from sunflower. Actually the same, but I included the one just now because this one is for verbal children because they can localize pain. Okay, next one. Next slide. Okay, so when do we intubate patient? Okay, basic one is when GCS is less than 8, right? Okay, but other consideration is when there is obstruction in the airway or there's compromised by the vomiting, airway is compromised, respiratory rate too low for adequate ventilation, or SpO2 remains 92% despite high flow oxygen we give, or any maneuver we try airway opening maneuvers, or there is any sign of shock despite fluid resuscitation. Okay, and the last but not least, signs of exhaustion. Okay, this is based on the guideline. However, based on my reading, what is exhaustion is it is a weakness like fatigue, which is we can see based on hypotonia of the patient, or we can see if there is any reduce in physical performance like irritability. Okay, so the next slide is about okay, we have to look for the common causes. So in patient with loss of consciousness, altered consciousness, we have to look for these 4 things, which is sepsis, shock, seizure, and raise in intracranial pressure. So the one thing that is very important today, we would discuss about raise intracranial pressure, which is because if there is raise in intracranial pressure, what will happen? It will complicate to brain ischemia. So brain ischemia would also lead to cerebral herniation. So if there is a cerebral herniation, it will lead to irreversible damage or even death. So that's why we have to look for ICP, increase in ICP. Okay, so clinically, we can look for ICP by fundoscopy for papillary edema, or recommended by the guideline, these 2 out of the following 5, which is GCS less than 8, pupils, unreactive or unequal pupils, abnormal dorsal eye reflex, decorticate or decerebrate posturing, and last but not least, abnormal breathing, kystokes or apneustic. So 2 out of these can be considered as raised intracranial pressure, so we would be precautious. Okay, number 1, we would treat raised intracranial pressure. Number 1 is pupillary signs in coma. So in coma, we can find patient can be pinpoint and fixed pupil due to opiates or barbiturates or any pontine lesion. Number 2, pupil can be fixed and dilated in severe hypoxia or during or post seizures or any anticholinergic drugs or hypothermia. Or it can be unilateral or unequal dilated pupil due to the expanding ipsilateral lesion, or if there is any herniation, third nerve lesion, or seizures. Okay, so basically in the brainstem, kan, if you remember our nucleus of oculomotor, if the stentorial herniation is happening one-sidedly, then it would compress the brainstem, the nucleus in the brainstem. So that's why it can happen, it can lead to unilateral dilated pupil. Basically, this unilateral is to just one side. Okay, next one, next slide. Okay, dorsal eye reflex is vestibulo-ocular reflex. Basically, we turn the reflex that we turn it, the eyes would counter rotate against the direction of the rotation. Okay, eyes will be away from the face. So if the vestibulo-ocular pathway is interrupted, what will happen is the eye will follow. Okay. So in case of brain injury or any what will happen is this dorsal eye reflex is absent. So any dorsal eye reflex. Okay. So the next one is abnormal posturing. Abnormal posturing, decorticate and decerebrate posture. Decorticate posture is when there is a damage in the midbrain, upper midbrain, above the midbrain, meaning cerebral, everything that is above the midbrain. If upper pontine, decerebrate posture. Okay, so the underlying mechanism is because of the pathway itself. The extensor, okay, basically when you have lesion in the brain, what will happen is all muscle can still be will be extended. This is involuntary muscle movement. It will be extended if there is lesion in the cortex. But flexion can be absent or present depending on the lesion. Where is the lesion at the brainstem? Okay. If the lesion is at the pontine, the flexion is because the nucleus support motor response flexion is in brain. Okay, this is basically
the voice is not clear. The voice is not clear. Try to adjust the mic, please.
Oh, okay. Can you hear?
Yes.
I don't because my headset is not working actually. I'm using external microphone.
No issue. It's good. It's okay.
Okay, so back to the so you have to remember the physiology of the pathway for motor response. So basically we have for extensor muscle we have both cortex and we have cortex response, and for flexor muscle we have both cortex response and red nucleus, which is in the cerebral spinal tract. So cerebral spinal tract ni nucleus is at the upper pontine. So that's why in the decorticate posture, even though the cortex is compromised, we can still flex. because we have the nucleus. The nucleus is below the lesion. Okay, if the cerebrate is when everything is compromised, all the brainstem is compromised, we cannot do anything. So only extend. Because extension, dia punya pathway is there is another nucleus that is that receive from spinal cord punya information. The ascending reticular activating system. Interesting Nanti you can revise back. Okay, next. Okay, so abnormal breathing is also depending on the brainstem. If you remember, we have the respiratory center and based on the pons, upper and lower. You have to revise back because based on this lesion, we can know it can come with what pattern of breathing. Like for example, Kine-Stokes breathing is when the lesion is in the forebrain. The Kine-Stokes pattern is gradual increase and decrease suddenly, periods of apnea. The wave, as you can see the wave, Kine-Stokes. So another one is apnostic breathing. Apnostic breathing is when there is prolonged expiratory phase and suddenly halt, stop, shorten expiratory phase. This is apnostic. Okay. So these two abnormal breathing can indicate intracranial pressure increment. Oh, I would like to add just now, abnormal posturing kan. If the patient has decorticate and suddenly progress to the cerebrate, meaning the underlying may be herniation. Does it make sense to you that when the herniation happens, before this is midbrain and suddenly occur at the pontine, then they will come to the cerebrate posturing. So that's why it is Glasgow Coma Scale 2. So it needs a very aggressive intervention. Okay, next. Okay, so that is raised intracranial pressure. After we have looked and tried to treat the raised intracranial pressure or seizure or shock or sepsis, these three, as we can look for the underlying etiology. We would try to consider, we would go on towards the secondary assessment. So basically ask for the history, ask for the age. For example, it's in traumatic brain injury. We can consider someone who is 14 years old and 8 years old, meaning 4 years old and above, can be due to fall injury or motor vehicle accident. But less than 4, we would be suspicious, especially non-accidental injury. Okay, and the next one is onset. If the sudden loss of consciousness is sudden abrupt, then we would think of trauma, seizure, hemorrhage, intoxication. If it is gradual, we could think of infection or any metabolic derangement, space occupying lesion, because it takes longer gradual time to develop. And then we would look for associated symptoms like infection, fever, rash, meningeal symptoms, irritability, history of traveling, especially meningococcal, and then increased ICP if there is headache. So vomiting would be projectile vomiting, nausea, blurry of vision, inconsolable crying, irritability. And then if we consider electrolyte imbalance, we would look for weakness, any GI loss, poor oral intake. And for fitting, we would have to dig more the nature, the duration, what is the post, pre, what happened during, and trauma. We have to dig for history of fall, any bruises at the area for non-accidental injury, for tumors, constitutional symptom, the growth chart, past medical, constitutional symptom, and then past medical history, we will look for any underlying illness, like renal, or diabetes mellitus, or if there is any previous episode of loss of consciousness, that could we could think of inborn error metabolism, and then drug history, any ingestion of drugs or toxin, anticonvulsant or antihistamine. For family history, we would look for consanguinity in inborn error metabolism or family history of malignancy, and social history would we have to dig more due to non-accidental injury. We have to know in detail. Okay, next thing. Examination. So basically, the same. We will look for general examination appearance, ill or toxic looking, any rash, purpuric rash, meningococcal purpuric rash, jaundice, hepatic encephalopathy, cachexia for suggestive of cancer or signs of dehydration, and any abnormal posture, decelerate, discorticate, and vital signs. If hyperthermia, we would think of inflammation, infection, status epilepticus, or heart rate, tachycardia, we would think of shock or bradycardia in hypoxemia, increased ICP, Cushing triad, right? So respiratory rate, tachypnea for any hypoxia or pontine injury would be this respiratory rate, basically the breathing pattern just now, and bradypnea if there is any sedative intoxication or diabetes ketoacidosis. Blood pressure, hypotension for shock, adrenal insufficiency, intoxication, hypertension. If there is an increase in intracranial pressure, would be hypertension. And we would do head examination, especially if we suspect acute hydrocephalus. Look for macrocephaly, dilated veins, head circumference. Look for bulge or tense fontana for increased cranial pressure. And then eye examination, the most important one is just now fundoscopy pupilledema, but we can look for I think this one for papillary pupil punya appearance, response to light, retinal hemorrhage in fundoscopy, sunsetting eye for hydrocephalus, and neurological examination for posture, assess the level of consciousness, Koenig and Brzezinski signs, and also upper motor neuron and lower motor neuron punya examination. Other system examination based on the differentials like hepatic encephalopathy. So we would look for hepatomegaly or all the signs and symptoms of chronic liver disease. If there is respiratory failure, we would examine the respiratory system. So these are further simplified in the next slide. Oh, so this is example of papilledema. Okay, this is based on the cause. For infection and meningitis or meningococcal encephalitis, these are the brief history and examination you should look for, and the diagnostic investigation we can do. Okay, so we consider infection just now, sepsis, seizure, shock, and increase in ICP. SSSIP, SIP. Okay, so next. Okay. So for metabolic derangement, diabetes mellitus, hypoglycemia, IEM, hepatic failure, acute renal failure, poisoning, shock, hypertension, and respiratory failure. So these are the history examination, the brief history examination that we should look for. For diagnostic investigation, next slide. Okay, so for blood and basic investigation, that is recommended to look for is the 6 full blood count, which is to look for anemia, shock, signs of infection, leukocytosis, and the differential to look for what is the cause, either it is bacterial or viral, and then the renal profile to look for electrolyte imbalance, hyponatremia, urea level for uremic encephalopathy, and blood culture and sensitivity for sepsis, liver function test for hepatic encephalopathy, and then serum ammonia for hyperammonemia, and then urinalysis, both for septic workup and non-septic workup. And then it is recommended for imaging. Yeah, doctor.
Sorry, lumbar puncture is not recommended as a routine in patient of loss of consciousness. Take care.
We have to delay lumbar puncture.
Yeah, if you write to be considered, but timing must be after CT, after otherwise cause herniation. So must put in brackets, okay?
Okay,
After
noted.
all the ICB.
Yeah, after all the imaging, then we can do after the child has is stable.
It depends on the consultant. After rule out increase intracerebral pressure. Maybe go for papilledema, go for CT as if, okay?
Okay. Okay. Others. Wait. It is also we have to do urgent CT or MRI in all children after stable. Or if it is traumatic brain injury, we have to do urgent CT scan. For MRI, if the diagnosis is uncertain, after 2 days, we would do MRI to look for other causes like ADEM or ANEC. And then other diagnostic screening would be EEG, IEM screening, blood for malaria, parasite, toxicology, or vasculitis screening. Okay. Okay, last but not least, the management. The goals of management is basically to stabilize the patient. We have to stabilize the patient and treat the underlying causes. So next, treatment of increase in ICP. This is the summary. We have to elevate the head up, back of about 15 degree to 30 degree, maintain good oxygenation, balance fluid and electrolyte balance, resuscitation, and then maintain cerebral blood flow of more than 50 millimeter mercury, which is cerebral perfusion pressure is equal to blood pressure minus intracranial pressure. So the next one would be hyperosmolar therapy. So basically, we would like to cater the osmotic gradient for CSF to be decreased. So we will give IV mannitol 0.25 to 0.5 gram per kg and hypertonic saline like 3% sodium chloride or if needed surgical decompression if these measures fail. So it is to be remembered that this is a medical emergency. We need to treat it urgently to prevent herniation. Although this is just transient, but we can still reverse the herniation in minute, if not severe damage. Okay, next. Okay, this is just a detail technical from the guideline, which is just now, nursing position head in the midline, elevate head 15 to 30 degree for and avoid unnecessary suction procedures, avoid hyper or hypothermia, which could complicate and avoid internal jugular central venous line, which would interfere with the MAP. And then ventilation, we would give adequate sedation and analgesia, maintain good oxygenation, and avoid excessively high PEEP. PEEP is basically the same as just like CPAP, high pressure. We would not do PEP because it would increase in intrathoracic cavity. When there is increase in thoracic cavity, there would be decrease in venous return and hence decrease in blood pressure. So what we would like to do is we would like to maintain the blood pressure just now, right? Because if you can look at the formula, cerebral perfusion pressure at the bottom is equal to mean arterial pressure minus intracranial pressure. So that's why we won't give high PEP. Okay. Fluid and electrolyte balance, we have to be we have to also consider hyponatremia, like symptoms of inappropriate antidiuretic hormones. So we have to respond accordingly. Like if there is hyponatremia, but there is high urine output, then we would consider cerebral salt wasting. So we have to replace the sodium loss. And then if hypernatremia, maybe diabetes insipidus. So we have to respond with maybe consider desmopressin. Okay. So just now we have to keep CPP above 50 millimeter mercury. So we would try to maintain the increment of blood pressure. So we don't do PEP just now, right? Because it would lead to decrease in blood pressure. Okay, next. Okay, for hypoosmolar therapy, we could consider ivermectin or hypertonic saline, like I have just mentioned just now. And it is recommended in hypotension, but we have to avoid in hyponatremia because prolonged mannitol can cause prolonged mannitol. Okay. Okay, prolonged mannitol can cause rebound, increase in intracranial pressure or acute tubular necrosis.
That's why now many clinicians go for normal saline 3%.
Oh, okay.
Many study said it is the same. Okay.
Mm-hmm. Okay. So last but not least, the surgical decompression if all the medical measures fail, like external ventricular drainage or decompressive hemicraniectomy. So the next slide is about outcome. The outcome for patient with altered consciousness will be depending on the underlying causes. 1/3 will lead to death. 1/3 will recover, but with deficit, neurological deficit, or 1/3 will recover completely. So it depends on the okay. So acute complication can improve with time. Example, after we remove the cause, like cortical blindness, motor deficit, depending on the lesion. If we remove the cause, then the acute complication can improve. So the next point is hypoxia carries poor prognosis because if there is rapid damage to the brain, the ischemia can lead to neurological deficit. Okay. Other factors is duration of the coma or age of the patient. Like children have better outcomes than adults, where children have better outcomes than adults. Yes. Okay. So thank you. These are my references. Is there any question?
Again, I need to assign one of you to write article to the group about how to write the reference, because all of you are writing a reference by non-scientific one.
Oh, okay.
Okay, who will be the one? And he send me a copy of what he did, please.
Okay.
Okay, anyone need to ask questions? So now you can realize that we must have a big size software in our brain for every patient coming to us. It is not simple job to do that. We get an important point that we have initial or primary assessment and the secondary one, because primary I need to stabilize the baby. I will go through the ABCD like that. At the same time, there is another one trying to squeeze the history from the family to see where am I going, what is the cause, so we will consider it. If you don't do the resuscitation on the ideal time, the result will be bad. Okay, I think now they are doing like cooling brain for some cases of arrest, but still in children, there is no experience for that. Okay. You speak about the importance of intubation because respiratory support is the number one, and it is very important. Okay, so some skills must be very ready in your hands. How to intubate, how to insert line, how to interpret the ECG, how to like that, to even to interpret the investigation wise. If you are not fully conscious about the thing in front of you. You miss hyperglycemia, you miss hyperkalemia. All this can cause a lot of problem and loss of consciousness. Okay, let us go for the second presentation.
Okay, can everyone see my slide?
Yes.
So let's proceed with a push to start with joint pain. So my name is Nur Afika binti Abdul Ghaffar, metric number 1610996. Okay, so bear in mind that childhood joint pain will have broad range of differential diagnoses, in which it can be benign or malignant or even emergency cases, for example, septic arthritis. Okay, so this is my outline. First we go to the differences between arthritis and arthralgia. So literally arthritis is defined as arthron, joint, and itis, inflammation. So basically it's a joint swelling with the presence of two or more of the following, which joint pain with motion, decreased range of motion, warm or erythema of the overlying joint. Or in simple word, there is all the five cardinal signs of inflammation is present. And also patient may be present with gait disturbance, fever, fatigue, and stiffness after physical activity. So it's a gelling phenomenon, which means that it's a condition that occurs when the joint has been too long at rest and thus the synovial fluid thicken. Okay, for arthralgia, it defines as arthron joint and algia pain. So basically, it's a presence of joint pain, but without objective signs of inflammation. For example, there is no warm, there is no erythema, there is no tenderness or swelling on physical examination. So this is the classification of arthritis. Can be classified into inflammatory or non-inflammatory. And then the inflammatory can be further divided into seropositive, seronegative, infectious, and crystal-induced. Okay, so this is the differential diagnosis of children with joint pain. That is taken from American Academy of Pediatrics. So it can be classified into inflammatory, non-inflammatory, trauma, infection, malignancy, hematologic problem, and orthopedic problem. So the common differential diagnosis would be the inflammatory, the trauma, the infection, malignancy, or orthopedic problems. So this one is taken from Nelson's Textbook of Pediatrics 21st edition, but basically it's more or less the same as the previous slide. You can read it later. Okay, so how to approach children that is presented with joint pain. So first, as usual, we'll take full history of presenting illness, and then we'll perform clinical examination, and then we will order investigation and also come to the management. So we go by one. So for the history of presenting illness, this is the things that you should ask the patient or the children or the parents. So how many joints are involved, whether it's monoarticular, oligoarticular, or polyarticular, that will give you signs of the possible diagnosis of possible diagnosis, or also ask whether it's rheumatic causes or non-rheumatic causes, either it's acute or chronic, benign or malignant, or other systems involvement. For example, in SLE, it's a multi-system involvement, right? Okay. So for the first one, the joint involvement. So for if it is monoarticular joint involvement, this may suggest septic arthritis, osteomyelitis, trauma, monoarticular juvenile idiopathic arthritis, or TB arthritis. For polyarticular joint involvement, this may suggest systemic disease. Yeah, for example, in acute rheumatic fever, we have migratory polyarthritis. And for involvement of small joints, we might suspect JIA, sickle cell disease, tubercular dactylitis, or psoriatic arthritis. Okay, so this is basically more or less the same as the previous slide. Monoarticular, what is the possible differential diagnosis that may present with monoarticular arthritis. Okay. Next is second presentation, fever. So we have to ask the patient whether the fever presented together with the joint pain and swelling So this may suggest acute infection, for example, septic arthritis or acute hematogenous osteomyelitis. Or if the fever presented prior to the joint pain, then this might suggest reactive arthritis or post-infectious arthritis. And then we also might need to ask the pattern of the fever, whether it's quotidian. So it might suggest GIA or gradual onset low-grade intermittent fever. This may we may suspect SLE. For long-standing continuous low-grade fever, then we might suspect TB arthritis. Okay, the third one is pain, stiffness, or swelling. So I know you guys is very familiar with this Socrates. So this is you should use Socrates for to take history of pain, stiffness, and swelling. So for example, you ask the site or location of the pain, and then the onset, whether it's sudden or gradual, characteristics for the pain, whether it's dull, aching, or sharp, stiffness, if there is any early morning stiffness, for swelling, is it warm to touch, and then the radiation. But basically, for in joint pain, we are not asking the radiation, but we are asking, is there any migratory pain, for example, in acute rheumatic fever. And then associated symptom, for example, in juvenile dermatomyositis, patient may be presented together with weakness. And then timing for acute versus chronic, that may lead to either septic arthritis or TB arthritis. Exacerbating or relieving factors, whether patient the pain is improved by rest or worsened by rest. And then the severity, whether patient is able to wet bear, is there any limping without pain, or the pain that causes patient to wake at night, and any interference with patient's daily activities. Okay, and then the fourth one is precipitating factors. For example, is there any antecedent trauma prior to the presentation of joint pain? So this may suggest fractures or ligamentous injury, for example, in sports injury. And then antecedent infection, if so, it may suggest reactive arthritis or osteomyelitis, uh, or any inactivity or increased physical activities that may suggest mechanical syndrome, for example, patellofemoral syndrome or Marfan syndrome. Okay, so this and then the fifth presentation ataupun fifth associated symptoms, we might ask extra articular symptoms. So for example, dermatological system, then we might ask malar rash or hair loss, Gottron's papules. So this table is basically to suggest the differential diagnosis together with the systemic or extra articular symptoms. Okay, you may read it by yourself. Okay. Uh, so this is another systems: gastrointestinal system, genitourinary system, hematological system, and neurologic system. So, for example, in SLE, IBD, patient might present with weight loss or poor growth, diarrhea or abdominal pain. And then in SLE, especially, patient might present with seizures and psychosis. If it is severe enough, it may present with seizures and seizures and psychosis. Okay. So this is important because this is the serious diagnosis and associated findings in children with joint pain or swelling. So for example, in septic arthritis or osteomyelitis, basically these are the emergency cases. So septic arthritis or osteomyelitis, patient will be presented with spiking fever, monoarthritis, rapid onset monoarthritis, pseudoparalysis. So these are very important. Why pseudoparalysis? Basically, pseudoparalysis is the patient refuse to wet bear because when they wet bear, the they they will feel pain, so they refuse to wet bear. Okay. So and then for Kawasaki disease, patient will be presented with cervical lymphadenopathy, conjunctivitis or mucositis, and etc. as written. And then for neoplasia, it's if patient presented with pallor, unexplained bruising. So this is very serious. And the last one is non-accidental injury if there's any abuse to the child. So basically for non-accidental injury, usually the history and the features of examination is not in disparity, which means that the parents said A, but the features of on examination is B. So the next is physical examination. After we have taken full history of presenting illness, all other histories, so we proceed with physical examination. So first, general examination, local examination of the joints, as we learned previously, look, feel, move, and other systems investigation examination. So for general examination, we should look for any septic looking child. Is there any pallor or jaundice? Any oral ulcer that might suggest SLE? Is the growth of the child appropriate to the age? So if it is not, then there might be some serious or chronic disease that affect the growth of the child. And then vital signs, whether it's normal or elevated. Hands and peripheral, for example, in juvenile dermatomyositis, patient will be presented with Cotron papules, and then rashes if present. For example, in SLE, we might see any mala or discoid rash in the child's face. Okay. So these are the examples. So mala rash, salmon colored rash in GIA, purpuric rash in HSP, Cotron papules in dermatomyositis. Okay. Okay, next is local examination. So as we all know, look, feel, move. So first for the look and feel, you have to look for the signs of inflammation, and feel, which means that you palpate for any tenderness, and then look for any atrophy, any deformity, for example, limb line discrepancy, fixed flexion deformity. Okay. And for move, we assess the range of motion of the joint and also patient's gait. So in joint pain, we know the patient will have antalgic gait, or so known as the. So how do we know it's antalgic gait? Is because of the short stance phase. So you assess the gait cycle of the child. So if there is any short stance phase, then this might suggest antalgic gait, which means that patient might have joint pain. And then other systems, for example, in SLE, we might do cardiovascular examination if there is any pericardial rupture that we suspect, or in respiratory systems, any fine crackles or pleural effusion that might suggest tumors that has metastasized to the lung. Okay, so this is the pediatrics gait, arms and legs. So basically, this is to assess the child's arms and legs gait. Okay, so first you use the screening question. So ask the child or the parents, is there any pain or stiffness in the joints or muscles or back, and then ask if there's any difficulty in getting the patient dressed without any help, or any problem in going up or down the stairs. Okay. So first screening the screening maneuvers. So observe the child standing from front, back, and sides as usual. And then what is being assessed is in this time is the posture of the child. And also we might assess any skin rash of the body, or deformity, or any scoliosis or swelling of the joint, muscle wasting, or flat foot. Okay. And the second one is we observe the child, how the child walks. So whether the child walk on ask the child to walk on his heels or walk on tiptoes. So this is we want to assess the ankles and the small joints of the feet and toes. And also we want to assess the foot posture, whether there is flat foot, as I mentioned just now. Okay, and then ask the child to hold the hands out straight for to assess the forward flexion of the shoulders, elbow extension, wrist extension, and small joints extension. And then ask the child to make fist. So this is to to assess the wrist supination, elbow supination, as well as flexion of the small joints of fingers. And then ask the child to pinch the index finger and thumb together. This is to assess the manual dexterity and coordination of the small joints of the index finger and the thumb, and also to assess the functional key grip of the child. Okay, the other screening maneuvers, I think you can read by yourself. Okay, so moving on to the investigation. So as usual, we divide into blood imaging and advanced or invasive investigations. So first, for the blood investigation, we'll do full blood count, renal profile, liver function test, acute phase proteins, for example, ESR, CRP, blood culture and sensitivity if we suspect any infection, for example, septic arthritis or osteomyelitis, and autoantibodies if we suspect SLE or any connective tissue disease, and serum creatine kinase, anti-streptolacin O titer, anti-streptolacin O titer, and coagulation profile if you suspect SLE or hemophilia. Okay. Next is imaging and advanced investigation. So for imaging, we should order plain radiograph of the joint or ultrasound, and in advanced cases we might order MRI if we suspect any malignancy. For advanced investigation, for example, if we suspect myositis, then we might have to do muscle biopsy, and then electromyography, and joint aspiration. Joint aspiration is very important if you suspect septic arthritis. Okay, next is management. So for management, it classified into its causes. So for inflammatory causes, then we shall manage the patient with NSAIDs, DMARDs or steroids, or even cyclophosphamide. And for infection, of course, if it is bacterial infection, then of course we have to manage by antibiotics corresponding to the causative organisms. Okay, for malignancy, we manage by chemotherapy, radiotherapy, immunotherapy, or even surgery. Okay, so this is just the type of the one of the management. For example, if a patient with hemolytic anemia with G6PD deficiency, then we might manage with sulfasalazine. Okay. Next, this is the therapeutics management for childhood rheumatic disease. So as you can see here, the steroids that we usually use, prednisone or methylprednisolone. This is indicated in SLE, GIA, vasculitis. Okay, and then IVIG usually we use in patient with Kawasaki disease. Cyclophosphamide is also sometimes used in managing patient with SLE. Yeah, so this just the medications, the drugs that are used in certain disease of joint pain. Okay, so I'm not sure if you need to see this, but it's just the overview of the disease in pediatrics that presented with joint pain. So we go one by one. It's just a short and simple one. So for juvenile SLE, as we all know, the clinical manifestation, it involves multiple organ system, and then usually in juvenile SLE, it is more severe than adult because it might involve the renal, cerebral, and hematologic systems. So, so how do we treat? By prednisolone or steroids, and then immunosuppressive drugs, for example, azathioprine or cyclophosphamide, and hydroxychloroquine if required. Okay. Or other drugs, for example, NSAIDs, calcium and vitamin D, antihypertensive if patient has developed lupus nephritis. So this is just the criteria for classification of SLE. I guess you all know about this, so I don't have to explain. Okay, next is juvenile idiopathic arthritis. So JIA is a diagnosis of exclusion. So it has unknown etiologies. And usually its onset is before 16 years old, and usually it persists for at least 6 weeks. So it can be classified into oligoarticular, polyarticular, or systemic JIA. So the treatment is as stated in pediatric protocol. So for oligoarthritis, we might manage patient using first line NSAIDs or intraarticular steroid injection and methotrexate, which is sulfasalazine. Okay, for polyarthritis, we might require NSAID, DMARD, pulse intravenous methylprednisolone or pulse oral prednisolone or intraarticular steroid injection of the targeted joints. And also, we might consider DMARD combinations or biologics. Okay, but for polyarthritis, we should remember to always screen for uveitis. And then for systemic GIA, it's basically more or less the same as polyarthritis, with the additional to avoid any gold or penicillamine because this will leads to macrophage activation syndrome. Okay. Then the next diagnosis is juvenile dermatomyositis. So patient will be presented with proximal muscle weakness, shawl sign, heliotrope rash, Gotron papules, as I mentioned just now. So for investigation, we might order muscle biopsy and EMG. Okay, treatment is as usual steroids and methotrexate. If required, we might add folic acid. Okay, so you can see picture here, the rash of the juvenile dermatomyositis, and also there is a Gotron papules over the metacarpal and proximal interphalangeal joints. Okay. The next one is septic arthritis. This is an emergency case. Remember the Koch's criteria for septic arthritis in a child. So Koch's criteria is used for septic arthritis of the hip joint in pediatrics. So they have four score. Whether patient is on weight bearing, the SR is more than 40, CC more than 12, or temperature white blood cell more than 12, or temperature more than 38.5. So if the score gives the percentage of whether it is septic arthritis or not. So if only 1 out of 4 score is present in this chart, then 3% 3% that this is septic arthritis. So that's how you scoring the Hodges criteria. So investigation, of course, we have to do joint aspiration and culture, and ultrasound can also be used to detect the effusion. So how do we manage? So for neonates, we require 6 months penicillin plus third generation cephalosporin. For older children, we might require flucloxacillin and fusidic acid.
Not 6 months, 6 weeks.
Neonates to 6 months. The age of the child.
You mean I mean
Uh,
okay.
okay. Next is Kawasaki disease. So it's a systemic febrile condition which usually affect child with less than 5 years old, and it is a mucocutaneous lymph node syndrome. So this is the diagnostic criteria for Kawasaki disease that is taken from pediatric protocol 4th edition. So this is the presentation that maybe this is the presentation might be present in the chart. So there might be triangular desquamation, bulbar conjunctiva congestion, strawberry tongue, or indurative edema of the hand. Okay. So basically, this is just the clinical and lab features of Kawasaki disease, as well as the how do we come to the diagnosis of Kawasaki disease. So if patients with fever at least 5 days and more than less than 4 of the principal criteria, then they can be diagnosed with Kawasaki disease. I'm sure you guys are very familiar with Kawasaki disease. So the treatment, as discussed previously last week, primary treatment is of course IVIG, and then IVIG aspirin, and then for maintenance we might require aspirin, and if there is presence of if coronary aneurysm present, then we might continue aspirin until it resolves. And if the causative doesn't respond to the primary treatment, then we might require we might repeat IVIG, 2 gram 2 gram per kg infusion over 10 to 12 hours. And also vaccination might be useful because the use of the IVIG will impair the efficacy of live attenuated virus vaccines. So because of that, because we treat patients with Kawasaki disease with IVIG, so we might have to delay the vaccination for at least 11 months. Okay, so the prognosis of Kawasaki disease, we know it's most of the aneurysm will resolve. Okay, and then another one is acute rheumatic fever. This is very common as well. So this is the criteria for to diagnose acute rheumatic fever, the major criteria and minor criteria, together with the uh, blood cultures of group A, group A, group A beta hemolytic streptococcus or elevated anti-streptolytic hepatitis. Okay, I just want this is just I just want to ask questions to you guys. Okay, so this is a case. A 2-year-old presented with high-grade fever and malaise, a salmon-colored rash present at times of fever. So investigation showed raised acute face reactant, and then shortly afterwards, he developed severe polyarticular joint disease. So Shahmi, uh, what would be your possible diagnosis?
uh, JIA.
Okay, okay, true.
طب,
Tahniah.
you must change the question. Don't write salmon colored, because if you wrote salmon colored, all will know.
Okay.
Okay,
Okay,
and this
doctor.
situation, yeah, you're good if you need to be a lecturer. You must do that. You just put the characteristic of the rash.
Okay, okay.
Okay.
Okay, next case is 8-year-old boy with severe pain on the bilateral wrist and ankle joint, with a history of fever, loose stools, and abdominal pain 5 days prior to the current presentation. Ifa Najwa, would you like to try? What is your possible diagnosis?
Yeah. Sorry.
Would you like to try your possible diagnosis of this patient?
I don't know.
Okay, it's okay. So because patient have infection prior to the presentation of the severe pain, so we might suspect post-infectious arthritis. Okay, so this is the result, HLA-B27 positive and Stukachi also positive for Salmonella. So patient have post-infectious arthritis due to Salmonella infection. Okay, next is 9-year-old boy, red raised rash on his leg and buttocks.
What is the
Uh,
difference between post-infectious and the reactive one?
Reactive one, in the pediatric protocols, the post-infectious arthritis is put below the reactive arthritis, which means that reactive arthritis can be post-infectious arthritis. So I'm not sure what's the difference actually.
No, here you picked already infection, so it is written as approved as infection. But even reactive arthritis can occur even with flu, with simple infection. You'll find the transient arthritis, but without increase in the inflammatory marker and like that. And it is one of the common. There is some people presented by that. Okay, it is very transient and no clue for any infection like that. But if proven infection, it is post-infectious. Okay.
Okay, thank you, doctor. Okay, next case. 9-year-old boy red raised rash on legs and buttocks. Knee appeared swollen, but he walked without difficulty. Otherwise, other investigations are normal. Um, I would like to ask Haikal the possible diagnosis for this child.
Probably HSP.
Yes.
Eh, HSP.
Okay, tahniah. Congratulations. Okay, so because of the red raised rash and knee appears swollen, so it might suggest Henno-Schwann purpura. Okay, next one is a 4-year-old girl limping intermittently for several weeks. And then at school, teacher at school commented she was quieter, less keen to play, and was not able to sit on the floor in story time. So on physical examination, noted that she had limp, right knee was swollen and restricted, and an A test was positive, and she had evidence of chronic anterior uveitis on slit lamp examination. Um, uh, yeah. Akila, would you like to try to answer the possible diagnosis? Hello, Akila, are you there? Okay, never mind. So I think the possible diagnosis would be oligoarticular GIA because patient has limping and the knee was swollen, and also patient has chronic anterior uveitis. Okay, last one is a 7-year-old boy presented with 1 month history of upper chest and shoulder pain. So on examination, there's a reduced range of motion in the shoulder, which is restricted by pain. So X-ray of the shoulder has normal findings, but ESR 90 millimeter per hour. So he was diagnosed with musculoskeletal injury and was given ibuprofen. But however, a month later, he complained of pain in hip, knee, and ankle joints bilaterally, and he was diagnosed with polyarticular GIA. Unfortunately, however, a month later, he was readmitted with severe pain and high-grade fever. Full blood count shows HP 8.1, platelet 1 to 1, and neutrophils 0.8. Okay, what further investigations you would request to confirm the diagnosis? Uh, Badrul Nizam, would you like to try?
Joint aspiration.
Okay. Investigations, which means it's more than one.
Blood culture to look for sepsis.
Okay. But okay, we shall do full blood picture because we suspect this patient might have malignancy because of the chronicity of the presentation. So we might do full blood picture that will show any blood cell that might suggest lymphoblastic leukemia, and also bone marrow examination to confirm the diagnosis of acute lymphoblastic leukemia. Okay, that's all for me.
Some cases of brucellosis can be presented like that. So if you are able to add these 2 points, brucella is famous to give sometimes arthritis and also Lyme disease. Lyme disease, if there is infestation and bites for some bugs, it can cause the same issue. It will start by fever, single skin rash, then arthritis, and if we stay, it maybe go for neurological signs. Okay. You need
Okay.
to ask Afika any questions?
Yeah, that's all from me.
Another way, a good she is able to present for us both sides, one side about what is the cause and one side about applied causes. Okay. Of course, the references we will adjust, please. Okay, now it is the role of Aliana. Why no boys today presented? Okay, go ahead.
Assalamualaikum. Assalamualaikum.
Waalaikumsalam.
Okay, sorry, my mic was having a problem just now. So, okay, so we move on to our last presentation, which is child with prolonged unexplained fever. Okay, next slide. Okay, so fever is defined by Nelson textbook as a rectal temperature of at least 38 degrees Celsius, whereas a value of more than 40 degrees is called as hyperpyrexia. So for fever of unknown origin, it is defined as temperature of more than 38 degrees Celsius for which the cause could not be identified after at least 8 days of evaluation. Okay, so next slide. So let's move on to the pathophysiology of fever. So as you guys know, fever is actually the result of a highly coordinated series of events that begins with the stimulus, such as the exogenous pyrogens, drugs, malignancy, or any inflammatory disease that leads to the synthesis and release of interleukin 1, 6, and tumor necrosis factor and other endogenous pyrogenic cytokines by the phagocytic cells in the blood or the tissues. So, in return, these cytokines will enter the blood and it is carried to the anterior hypothalamus where they will induce an increase in the synthesis of prostaglandin, especially prostaglandin E2, PGE2. So, the induction of PGE2 in the brain will raise the hypothalamic set point for the body temperature. So after the set point is raised, the thermoregulatory center recognize the current body temperature to be too low. So it initiates a series of events to raise the body temperature to the new set point. So it involves augmentation of heat production by increasing metabolic rate and also increase muscle tone and activity um, and also heat conservation by vasoconstriction and chills. Okay, so next slide. Okay, so for fever of unknown origin, FUO, it can be classified into four, which is classic fever of unknown origin. Secondly is healthcare associated FUO. Third is immune deficient FUO, and lastly is HIV related fever of unknown origin. So next slide. So for classic FUO, the definition is it affect the previously a healthy patient. So it is where the temperature is more than 38 degree, lasted for more than 3 weeks, or more than 2 visits, or 1 week in the hospital. So among the causes are infections, cancer, or inflammatory conditions. Secondly is healthcare associated FUO. So in healthcare associated FUO, the temperature is at least 38 degree for more than 1 week. So it is not present or incubating on admission to the hospitals. So the patient is generally admitted for other reasons but begin to develop unexplained fever afterwards. So the causes are mainly healthcare associated infections, which is nosocomial, or maybe post-operative complications or drug fever. So fever that is caused by the drug administered during the stay in the hospital. So the third one is immune deficient FUO. So for immune deficient FUO, it is characterized by temperature at least 38°C more than 1 week, and they can have negative cultures after 48 hours. So majority in immune deficient FUO, it is caused by infection due to patient is generally suppressed because the patient in chemotherapy, or they have underlying immunosuppressive disorder, or maybe they are on immunosuppressive drug. So the immune systems are weakened, so it means patient can get sick very easily, even by the normal flora of the body. Okay, and then the fourth one, which is the last one, is HIV related FEO, where the temperature recorded is at least 38°C more than 3 weeks for outpatients, or more than 1 week for inpatients, and it's confirmed to have HIV. So the causes can be because of the HIV itself, or due to opportunistic infections. Okay, next slide. So the etiology of um, ATO can be divided broadly into two, which is infection cause and also non-infection cause. So for infection cause, it can be caused by abscess. There are actually many, but I just list out the disease that is commonly found in the hospital. So such as abscess, localized infections, bacterial, viral, fungal, and also parasite infections. Whereas for non-infection, it can be due to inflammatory, such as SLE, JIA, Kawasaki, rheumatic fever, or IBD, inflammatory bowel disease. Secondly is neoplasms or miscellaneous. Okay, so the most common etiology is in order of frequency is actually infectious disease, followed by connective tissue disease and neoplasm. Okay, so for the miscellaneous, as you can see, there are factitious fever. So, factitious fever, it refers to a condition in which patient it produce or falsify the symptoms of illness for the principal purpose of assuming the sick role. So actually there are not sick. Okay, so okay, and then for periodic fever syndrome, it is a group of disorder in which a child has recurrent episode of fever over time, usually accompanied by the same symptoms. So each episode of fever usually lasts roughly the same length of time. So it is usually caused by rare genetic conditions. Okay. Okay. Next slide. Okay, so the approach, what is the approach to child with fever of unknown origin? Okay, so for history, so a detailed and thorough history and physical examination are actually the most important components of the diagnostic evaluation. As in FEO, incomplete histories or overlooked physical findings and failure to correctly interpret the laboratory data can delay the determination of underlying cause. So for the history, we ask about age because some disease are prone to occur at certain age. Okay, for example, with children more than 6 year old, they are prone to have respiratory or genitourinary tract infections, localized infections, GIA or leukemia. Whereas in adolescent, they are prone to have inflammatory bowel disease, autoimmune disease, lymphoma, or tuberculosis. And then we need to ask a detailed history on the fever itself, its onset, its frequency, duration, pattern of fever, whether it responds to treatment of antibiotic or not, and whether they have repetitive chills and temperature spikes that could suggest septicemia. Okay, next slide. Okay, so for pattern of fever, although the pattern and duration of fever actually are not helpful in making a specific diagnosis in children with FEO. However, certain fever patterns may suggest few possible diagnosis. Okay, so first one is continuous fever. So for continuous fever, it is a fever that does not fluctuate more than about 1 degree during 24 hours, but at no time it touches normal. So as you can see at the graph, the fever is rather constant, stable, but they are feverish throughout the day. Okay, it can be caused by loba or and gram-negative pneumonia, typhoid, or maybe urinary tract infections. Okay, next slide. So under continuous fever, also you can have continuous stepladder fever. So in continuous stepladder fever, it is continuous in nature, in which the temperature will rise gradually. As you can see at the on the graph, the temperature rises gradually to a higher level, just like the steps of the ladder. So this is usually a pattern of fever that you can observe in patient with in typhoid fever. Okay. Okay. Next slide. Next slide is intermittent fever. So for intermittent fever, the fever presents only for several hours during the day. So it is a type of pattern of fever in which there is an interval where temperature is elevated for several hours, followed by an interval when temperature drops back to normal. Okay, you can see this type of fever in paragenic infections, lymphoma, tuberculosis, or malaria. Okay, the graph showed the pattern of fever of malaria for different type of malaria. Okay, next slide. Okay, and the third one is remittent fever. So, remittent fever is a fever with daily fluctuation exceeding 2 degree, but at no time touches normal. So, the as you can see on the graph, the for remittent fever it fluctuates throughout the day, and they are continuously feverish. Okay, so it can be caused by infective endocarditis. Okay, so next slide. Okay, this is rather not a major type of fever, but is rather specific type of fever, which is Pelbston fever. In Pelbston fever, the fever will last for like 3 to 10 days, followed by a febrile period for 3 to 10 days. So it is highly associated in patient with Hodgkin lymphoma. Okay, so this is a rather specific presentation of Hodgkin lymphoma. Okay, so next slide. Okay, and then we need to ask the patient about the associated symptoms, um, such as chills and rigor that indicates a severe infection such as malaria, pyelonephritis, or bacteremia, and then rashes in juvenile idiopathic arthritis, and also Kawasaki. As in GIA, you can have the salmon rash, and Kawasaki, you can have maculopapular. And then for night sweats, that can be suggestive of tuberculosis, lymphoma, or HIV, red eyes, nasal discharge, any swelling or lumps that could suggest TB or maybe neoplasms, and then skin rash, malar rash, photosensitivity, which is suggestive of SLE, and then respiratory problems such as a cough, pleuritic, or maybe pleuritic chest pain that could suggest pneumonia, and then GI complaint, and then urinary tract complaints that can be due to urinary tract infections, and then headache, neurological complaints such as headache, photophobia, neck stiffness, that can be due to brain abscess, toxoplasmosis, meningitis, or maybe malignancy. And lastly is limb or bone pain that can be of osteomyelitis or septic arthritis. Okay, so next slide. Okay, we need to exposure is also an important thing to us, such as recreational activities, ingestion of outside food prior to illness, and any stick contact prior to fever, and also recent surgical procedures such as dental procedure that could predispose to infective endocarditis. Okay, next. Okay, we also need to ask about drug history, with whether the patient is in immunosuppressive therapy, because immunosuppression can cause FUO, and then recent drugs taken, because drug can also cause hypersensitivity reaction that could be the causes of fever of unknown origin. And then past medical history or past surgical history, whether there is a history of unusual, severe or chronic infection that could suggest immune deficiency, and then any malignancy that the patient has, abdominal surgery because it can increase the risk of intra-abdominal abscess, and then any tracheotomy tubes or implantable devices on administered in the patient that could predispose to infections. And then for family history of malignancy and also chronic illness such as TB. For travel history, we need to ask because some disease are prone in certain area. So we need to ask about history of traveling to any endemic area. And then prophylactic immunization and also exposure to other person with recent history of traveling. And then lastly is social history. We need to the address or the home of the patient is also important because we can maybe there is any outbreak in housing area that could uh, lead to that could be the cause of the fever of unknown origin. And also we need to ask about the impact of fever on child's health and also their activity. Okay, okay, next slide. Okay, for physical examination, okay, for general appearance, we can see whether the patient is cachexy or toxic looking, maybe patient is septic, or maybe patient in respiratory distress or in pain. For skin and nails, we look for maybe rashes. Actually, for physical examination, we it depends also on our differential diagnosis right? So we look for rash, skin peeling, as in Kawasaki you can have the peeling of the fingers and also the soles. And then petechiae, you can have petechiae in infective endocarditis, and also in spleen have spleen hemorrhage and maybe clubbing. Okay, and for the eyes, conjunctivitis that could be the symptoms of Kawasaki, and then raw spots and also proptosis that can be due to thyrotoxicosis. Okay, next slide. Okay, so for this is skin manifestation. As you can see in SLE, you can have malar rash or discoid rash, and then salmon pink rash is for GIA. So salmon pink rash is characteristic of GIA. It is characteristic of GIA. So the rash is brought out by heat and often can be found in the axilla and around the waist. But it may be present anywhere on the body. Okay, and then you can have skin peeling as in Kawasaki disease or erythema nodosum. So erythema nodosum is painful and it is found oftenly in symmetrical distribution on the leg. So it can also appear to be pigmented. So you can have erythema nodosum in children with GIA, SLE, malignancy, or maybe inflammatory bowel disease. Okay, next slide is oral. So for oral, you can look for ulcer, oral thrush um, that is suggestive of candidiasis due to HIV, red mucous membrane or strawberry tongue has been mentioned such and in Kawasaki disease. Okay, next slide. Okay, so for cardiovascular, we may look for new murmur that may be suggestive of endocarditis. For respiratory, you can look for crepitations or dullness to percussion that maybe pneumonia. For abdomen, hepatosplenomegaly. So some of the more common cause of hepatomegaly or splenomegaly in children with FUO include infectious mononucleosis, uh, infective endocarditis, and also malaria. And also you can have abdominal look for abdominal tenderness or loin tenderness. And for musculoskeletal, for bony tenderness, it can indicate osteomyelitis or even malignant infiltration of the bone marrow. And for joint tenderness or effusion, it can indicate joint infection, GIA or SLE. And for rectal examination, whether there is abscess or fissure that you can observe in patient with inflammatory bowel disease. Okay. Okay, for our next slide. So for investigation, there are basic tests and also additional tests. So these are basic tests that we should do for all patients that come with FUO, because the results of these tests may provide clues to the most common or serious causes of the unresolved fever. Okay, so the first one is full blood count and its differentials. So you can have neutrophilia, lymphocytosis, eosinophilia that can suggest parasitic or fungal infections, and anemia that can be caused by malaria or SLE. And then you can do tests for inflammatory markers such as C-reactive protein and ESR. So if it's more than 30 millimeter per hour, it indicates inflammation. And if it's more than 100, it suggests TB, malignancy, or autoimmune cause. And then blood culture, because blood culture may provide diagnosis in children with bacteremia, infective endocarditis, and then you need to do urinalysis and urine culture and sensitivity, because urinary tract infection is one of the most common causes of FUO in children. And the renal profile, look for sign of dehydration of maybe acute kidney injury. And then liver function test, as you can have high bilirubin in malaria, and also for imaging you can do chest X-ray. Okay. If you suspect any respiratory disease. Okay, for next slide is additional tests. So additional tests depends on the differential diagnosis. So it might be done or it might be not be done. It actually depends on you. So the first one is serological test if you suspect any autoimmune disease, or tuberculin skin test for tuberculosis, or imaging if you suspect infective endocarditis. You might do echocardiogram to look for presence of vegetation. Okay. Next slide. Okay, so for general management, so basically, the management of FUO depends on the causes. You treat accordingly. So you treat with antimicrobial if there is evidence of infections, or maybe if there is nothing that is abnormal in the lab results. Maybe you can do supportive therapy such as nutrition and hydration, because generally children that is sick, they have loss of appetite. And then you need to monitor the vital signs and give antibiotic and referral to if you think of any specific disease. Okay. And then the next slide is for the prognosis. So basically, if you give a good prognosis, because it is usually an atypical presentation of a common childhood illness. So in many cases, no diagnosis can be established and fever a bit spontaneously. In 25% of children in whom fever persists, the cause of the fever remains unclear even after a thorough evaluation. Okay, so that's all. Do you have any question regarding fever of unknown origin?
I have a question. Okay. Can you hear me, Aliana? Yes.
Yes.
Oh, okay. So, do we need to include the duration in the definition?
Okay, actually, the duration of what? Fever of unknown origin.
Yes.
Yes, because fever of unknown origin is at least 8 days of evaluation. If it is less than that, you think of it as fever with unknown source. That's a different topic. Sorry.
Because I have read somewhere that PUO is at least 3 weeks of having fever, right? So do we need to put it in the duration, in the definition?
Oh, I'm sorry, because the definition that I got is actually from Nelson textbook. It only write as at least 8 days. So I'm not sure about that. I'm sorry.
Yeah, there is a lot of discrepancy. Usually, if the patient inside the hospital, we will retrieve 8 days. If the patient is outpatient and not well investigated and like that, we may accept prolonged time to come to the conclusion.
Okay, thank you, Doctor.
Welcome.
Thank you, Aliana.
Okay, another question?
So now we realize that the body is a one part. Whenever you start, the other part will share. Starting by fever, starting by joint pain, starting by even disturbed consciousness, started by cutaneous manifestation. All this, sometimes the patient have panic from one symptom, but you must take care about the others. If you came with fever, you are going to check for the skin, check for the joint, skin for the other, like that. So please take care that the history is a gold standard to guide you to the diagnosis. And don't be in trouble to repeat taking the history. Even to us, sometimes came baby who is sick, and the ONG see the child and wrote all the notes. But sometimes the mother is very sick during the time she when coming to deliver. Anything she said either yes or no. Two option. When we ask again, when we got, sometimes you can get again the history. Okay, so always remember that. Re-ask the question because we are putting like a cycle of diagnosis. What is the complaint now? He has fever, but I can find some joint pain. Also, they give history of that one. Is it Kawasaki? Is it other? Is it so? The most important here is to be a good historian. Okay, the one who is getting history, he is able to come to the diagnosis. The second lesson, which is very important, the atypical presentation. As in the last one, yeah, there is now before when we are studying Nelson in 1980 like that, all things are typical. You read Nelson, you will find everything like he is describing the patient in front of you. This time, we started to hear about atypical presentation, even of common disease. We start now a lot of consultant or subspecialty speak about not fulfill the criteria, but he still can diagnose, like Kawasaki disease. The patient only has fever and small and some signs not for as documented in the criteria, but who put his echo and can diagnose aneurysm. So we'll come to the diagnosis. Even for rheumatic fever, many books like current speak about the possible rheumatic fever. He cannot say 100% it is rheumatic fever because it is out of the age, it is out of the criteria like that. So this make load for the clinician to be fully oriented about all these changes. Okay, today we cover a very, very, very important one, which is the fever. And we got important lesson, please don't forget to look to the curve of the temperature. Now it is inside the computer. You can know what is the criteria of the temperature curve, what may be the cause, when I am going to diagnose pyrexia of undetermined origin, what is the investigation. Of course, I cannot do blanket investigation. Blanket investigation, if the patient is going to pay, it is very costly. And if it is done on our healthcare session, it will be very burden also. So you must be able to put initial diagnosis. What can it be? Is it infection? Is it autoimmune? Is it malignancy? Is it? So I will define my pathway for investigation. Of course, there is some basic investigation must be done for all. Okay. So that is even during your presentation for any case presented for you, you will say like that. In that case, the patient is presented by blah, 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 blah. I will suspect initially the initial investigation. I would the first priority, which can be like what is the diagnosis, and I will consider. But if other investigation like that, so all this give us impression that your mind is here, is oriented about the different cause and how can we handle it. Okay, I think you did a good job. Hoping this knowledge with all of you, you can just revise and make benefit of that. Do you need to ask any questions? Okay. See you inshallah. When is our next seminar? Is it on Friday?
It's Friday.
Okay, please drop it to me a bit earlier so I can give you feedback if there is a time. Okay,
Okay, inshallah.
inshallah. And also Friday morning or afternoon?
According to the schedule, it should be morning.
Okay, hoping there is nothing will happen. If something happen, we may make it also on Friday, but maybe slightly late. But inshallah on time. Yeah. Okay.
Okay.
Okay. Okay. Thank you, and see you inshallah, and good wishes for you. Assalamu alaikum wa rahmatullah.
Waalaikumsalam.
Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Assalamualaikum.
Thank you, Doctor.
Assalamu alaikum wa rahmatullah.